Our first talk will be done by Ricardo Romiti. He's responsible for the psoriasis unit at the Department of Dermatology of the University of Sao Paulo in Brazil, and works as a clinical professor of dermatology also at the University of Sao Paulo. And he's an International Psoriasis Council board member. And we'll talk about infections in psoriasis patients treated with small molecules, biologics, or their combination.
Great, sorry. So this is my hospital in Sao Paulo, where I work. So when we think about infections and psoriasis treatments, we know there might be an association between specific treatments for psoriasis and infection. So we all know of the association between anti-TNF treatment and tuberculosis, the use of anti-IL-17 blockers and candidiasis and widespread dermatophytes infections, and even of the association of JAK inhibitors and the occurrence of herpes zoster, for example. But is there also an association between psoriasis as a disease and infections? Is the occurrence of infections higher in psoriasis patients? We know that for superficial bacterial infections, the risk is actually lower. We know that due to the enhanced production of this antimicrobial protein genes, the frequency of these kinds of infections tends to be much lower than in atopic dermatitis patients and even in patients with hidradenitis suppurativa. Concerning systemic infections, we know that there might be a higher risk of this kind of infections. We have interesting data from this Dutch study following over 25,000 patients during a 6-year period, showing that the risk of infections requiring hospitalization was higher in psoriasis patients when compared to the general population. And interesting that the magnitude of this risk was not associated with specific therapy of these patients, but much more with the severity of psoriasis. And we also know that erythrodermic and GPP patients are much more prone to have serious systemic infections. And what about biologics? Is there a higher risk for our psoriasis patients? If they have infections, when do these infections tend to happen? These are an interesting comparison actually from the rheumatology registry, showing that when we use biologic treatments, the chance of having serious infections is much higher during the first months of therapy, especially when we compare those patients treated with DMARDs as methotrexate, where this risk is much higher after a long period of treatment. The same data for hospitalization, here Swedish registry data, showing that at the first year, the risk of infection is much higher with biologic treatments. And what about the risk itself? We have very well done systematic reviews and meta-analysis of the literature. Here, looking firstly at anti-TNF treatments, showing that when we consider etanercept, adalimumab, and ustekinumab, there tends to be not a higher risk of these infections. Looking at registries, here we have the results of the British Association of Dermatologists registry, also showing not a significant increased risk of serious infections when we look at patients treated with etanercept, adalimumab, and ustekinumab, especially when compared with methotrexate or other psoriasis treatments. Here, data from the Spanish registry, Biobadadem, following over 2,000 patients between 2008 and 2015, showing that TNFs as a group had a higher prevalence of overall infections, and within the group of anti-TNFs, infliximab showing the higher risk, and ustekinumab having the lowest overall infection risk among biologic treatments. Similar data we have from this SOLAR registry, where we see at the left the risk of serious infections with ustekinumab much lower when compared to anti-TNF treatments and also to no biologic treatments. When we now shift to the newer anti-interleukin blockers, ranging from IL-17 blockers to IL-23 blockers, we see that the safety profile is present. Specifically, when we look at serious infections, we see that with all these drugs, from both groups, the prevalence of serious infections and of overall infections is very low. Now, considering tuberculosis, we know this is a very specific issue when we treat our patients with anti-TNF drugs, especially here in Latin America. We know that one of the serious side effects of anti-TNF treatment when we consider infections is tuberculosis. Why does this happen? We know that when we use these TNF blockers, we have a much higher risk of reactivation of tuberculosis. This might be as far as 9 times higher than within the normal population. We know that TNF has an important role of keeping the tuberculosis granuloma at its place. And when we start blocking TNF, we have a breakdown of this granuloma, allowing for the dissemination of Mycobacterium tuberculosis. So sometimes we don't have classic tuberculosis, only like pulmonary or pleural tuberculosis. We might have extrapulmonary cases, like this patient of ours developing a peritoneal tuberculosis during anti-TNF treatment. Another case, a very rare case of ocular tuberculosis occurring, and an even much rarer case of tuberculosis affecting the tongue. This was the only site of involvement at this patient. He didn't present any other signs of symptoms of infections like fever or malaise. The only site of involvement was the tongue. And the only way to really make the diagnosis possible was with a very deep surgical biopsy. So we know that we have to screen our patients for latent TB, not only looking at the X-ray, as the quantiferon or PPD, but specifically at the previous history of our patients or contact with tuberculosis. And we know that since we started doing this screening, the incidence of reactivation of tuberculosis dropped a lot. Here we see data from infliximab. Since the time, about the year 2001, this screening started to be done, we see a constant drop of the TB reactivation rates. When we look now again to the IL-17 and IL-23 blockers, and of course also to the IL-12 and 23 blocker, ustekinumab, we see that data in regards to reactivation for tuberculosis is very comforting. We know that the rates are extremely low. We have very few cases published in the literature of reactivation of tuberculosis when we use these neuromodality treatments. Candidiasis is another specific issue. When we think of blocking IL-17, we know that IL-17 has a specific role of blocking fungal infections, and that's not a surprise when we look at data from secukinumab, ixekizumab, and even higher rates when we think of bimekizumab, the IL-17 blockers that blocks IL-17A and IL-17F, when we have higher rates of candidiasis. Here we see a rate of about 3.5% of patients being treated with secukinumab developing this kind of fungal infection. And what about the small molecules? Concerning apremilast, the data we have from literature, not only concerning common infections like respiratory upper tract infections, but also herpes zoster, hepatitis C, and even tuberculosis. We also see that the rates are extremely low when we use this phosphodiesterase 4 inhibitor. And what about the JAK inhibitors, the neogenous kinase inhibitors? We know that these inhibitors block the enzymes, the JAK-STAT pathway, which should end with the transcription and the occurrence of this blockage ending in the nucleus of our patients with psoriasis. Here we see the different classes of JAK inhibitors. We know there are many new drugs in study, each one with its specific safety and efficacy profile. The main concern when we look data of infections with this class of drugs, we know that the overall rates overall rates of infections are very similar among all different JAK inhibitor classes, but the reactivation of the varicella zoster virus is one of the most concerning and recognized infections complications when we use this class of drugs. And this is probably secondary to the JAK-dependent functions implicated in the steps of the virus cycle in our patients treated with this modality treatment. This is my last slide. I thank your attention.
Thank you very much. We have time for some questions through the chat, but I would like also to ask you something about your experience with tuberculosis, and especially the need to repeat the testing, either quantiferon or PPD, periodically in some patients. You know, we all know that some guidelines have been put forth, but based on your experience in a country with a relatively high prevalence of tuberculosis, which is your approach in your patients?
Thanks for your question, Professor Puig. This is a very controversial aspect. We know that some guidelines propose that you should annually screen your patients with PPD and quantiferon, and others say that not. I will tell what we do at our department. Normally, we repeat the screening procedures when we have a history of contact of our patients with tuberculosis. So these patients went to endemic area or went to a specific site where the tuberculosis incidence is high, or the patients, of course, has any familiar that develops tuberculosis, then we do all the screening for our patients again. Why don't we do it annually or even more frequently? Because what we hear from the infectiology colleagues is that if a patient should have contact with tuberculosis during his anti-TNF treatment, he would probably develop the full-blown picture of tuberculosis and not just positivating his PPD or quantiferon and being asymptomatic. So it would come in a full-blown picture really when he gets contact with this infection. So normally we just do if there is a specific reason to screen these patients again. Otherwise, we just do the clinical and regular laboratory follow-up.
In the rare instance where you get a latent, so let's say seroconversion, quantiferon becomes positive or PPD becomes positive in a patient with in which you can rule out active tuberculosis, I understand you will start chemoprophylaxis, but will you perhaps do you stop treatment in those patients?
No, normally we don't stop. We maintain treatment. Here in Brazil, we maintain the prophylaxis with isoniazid during 9 months. In some places around the world, it's 6 months. But normally we don't stop treatment. And we know that before we introduce an anti-TNF treatment, it's regular enough if we wait 4 weeks with the prophylaxis before you start the blockage of TNF.
Excellent, thank you. We have one question from Professor Romiti.
Yes, Ricardo, thank you for this excellent talk. I have a follow-up question because this is one of the most burning issues also regarding writing our guidelines or renewing our guidelines in this respect. So we just talked about anti-TNFs. And what's your position with the anti-IL-17 and IL-23 class? Because they have shown us data that the risk of getting a latent TB reactivation is very, very low, and even in the threshold of the normal population. What is your, and we are aiming for a long-term treatment paradigm for psoriasis, namely 5 years and more. So what is your approach to a rescreening regarding anti-IL-17 and anti-IL-23s?
Thank you, Ulrich. What we do nowadays, we still screen our patients the same way we always did with anti-TNF blockers. But it's our personal opinion that in the near future, this necessity will probably drop, because we know the incidents are extremely low. We don't check our patients for latent TB when we introduce methotrexate and even systemic steroids for treating lichen planus, for example. We never do this because the rates of reactivation are low. So we know that the main concern is really with the blockage of TNF. It's specific of this class of treatment. But as far as I'm concerned, I think in many parts of the world, it's still mandatory to check for the same way we did in the past. But I think this will have a short-lived history in the future.
This will be for the beginning of treatment, Ricardo. But when you continue for 5 years, do you have the same procedure? You just ask your patients about possible contacts if they have a traveling history in areas where there is more tuberculosis than maybe in Sao Paulo. Is that what you're doing with the anti-IL-17s and 23s as well?
Yes, exactly the same. We don't screen.
Okay.
And we sometimes observe is that we just screen the patient. The patient is perfectly well, doing well in treatment, and he comes back with a PPD of 6 millimeters, for example. What would you have to do? You would have to start your chemoprophylaxis for 6 to 9 days with a drug we know that has some side effects like liver toxicity. But once you screen and you get a positive result, you can't avoid checking for this result and handling it. So it's sometimes a bigger problem if you just screen the patient without a specific reason to do that.
Okay, thank you very much.
Thank you.
Thank you very much. Excellent talk, a great discussion.